So now I'll invite Dr. Anand for his talk on atypical presentations of CSCR and exudative maculopathies. Dr. Anand needs no introduction. He heads the retina services at Arvind Eye Hospital, Chennai, and also is the chairperson of the scientific committee of VRSI. Over to you, Anand.
Thank you, Manisha. It's a pleasure to be part of this session. So I'll be talking to you about atypical presentations of CSCR and exudative maculopathies. Are my slides visible, Manisha? Am I audible?
Yeah, very much, Anand.
Thank you. So going on, before we delve into the the atypical, let's a quick look at the typical. This is how we usually see CSCRs with the classic in-plot leaks. Not very often we find CSCRs with the more dramatic smokestack leaks. And of the atypical presentations, obviously the teardrop ones are the ones we see quite commonly with the inferior atrophic gravitational tract seen more vividly on the fluorescein angiogram. Leak distortions are also seen, as you can be seen here. And this is very often because of subretinal fibrin tracking under the surface of the retina to that leaking PD beneath. Now, bullous CSRs often present with RP rips, and sometimes they can be massive. And no presentation of mine is actually complete without the reference to this iconic case, where we have an atypical CSR with a multi-pronged complex RPA rip with massive subretinal fibrin and inferior bullous detachment. And on the angiogram, you see that ripped out area with the exposed sclera underneath showing up, as one must say, a white lizard. And on the progressive angiograms, you find that the tail of the lizard is catching fire and the extrafoveal leaks are lighting up. The autofluorescence shows up the lizard in its negative. It's a dark lizard. The OCT shows at different levels. You see the vacuolated fibrin here, the RP rip there, and the minimal foveal detachment at this point accounting for the good acuity. So the TTT was done in this patient, could afford PDT, and there was a pretty good result at the end of 6 months and seen more dramatically on the montages. Bullous CSRs, when chronic, can rarely present with neovascularization of the iris. It's something which is not really recognized and something we reported. So this was a case who presented with the CSCR with the inferior bullous detachment. You can see paramacularly and peripapillarly, there's a lot of fibrin. And inferiorly, you find neovascularization, you find the subretinal precipitates mimicking choroidal infiltrates, and somebody can mistake one for the other. And in another location, you find a neovascularization. Again, these subretinal precipitates lining the vessels, simulating vasculitis. The angiographic leaks were seen temporally, and inferiorly you find the massive neovascular fronts there with significant amount of capillary non-perfusion. OCT showed a skytic macular edema with minimal detachment. The standout feature was the neovascularization of the iris, and we treated the patient again with 2 TTT spots. Patient could afford PDT. Next day, intravitreal avastin was put in, and 4 months post-treatment, you see a flat macula. The NBI was wiped out, and a complete regression of the CSCR and the fibrin, as well as angiographic regression. It was something we published in IA a long time back. Now, diabetic retinopathy, Dr. Shukla has elegantly showed as so many permutations and the presentations can often present with a chronic CSR also, and makes for a complex presentation. So this was a middle-aged gentleman who came in with severe NPDR and with serous macular detachment, a PED, and a mildly fibrinous subretinal fluid. Got a shot of avastin first up, and 4 weeks later, the SRF went away, but the fibrin remained and actually intensified, and the drop in acuity. And down the line, 6 weeks later, that intensified further, the fibrin, and on the angiogram, you can see the fibrin distorted CSCR leaks. We counseled the patient for PDT. Patient opted for conservative management, largely on account of the fairly decent vision at that point of time. But then 8 weeks later, there's a massive accumulation of fibrin, and the patient accepted and underwent PDT, and with remarkable resolution and a gain of equity. So this was the clinical sequence and profile of the patient from baseline through 4, 6, 8 weeks when the fibrin increased, and post PDT when it resolved. Now, this is a recent favorite of mine, a case which showcases what we believe that CSCR and uveal effusion syndrome are at opposite ends or at different force points of the pachychoroid spectrums. Now, our patient was a 56-year-old male with painless progressive diminution of vision over the last 3 months, diabetic hypertensive cardiac, left eye acuity 612, bilateral choroidal folds. I like to direct your attention to that. Serous macular detachment mild with some drusenoid changes, hard exudates. OCT showed pachychoroid in both eyes, and the foveal detachment and the peripapillary skytic edema. Angiogram showed hypopermeable foci pachyvessels on ICG, no classic CSCR leaks, staining of drusen on the angiogram and choroidal folds, and therefore we thought it was open shut case of pachychoroid with left eye CSR. Photodynamic therapy was done, and 1 month later, post PDT, gratifying results, CSR resolved, equity came back to 6.6. But 3 months later, to our consternation, we found recurrent subretinal fluid in the fovea and around the disc edema, and all signs of incipient uveal effusion syndrome. Equity slid down to 6.9, and a florid disc leak was to be seen. A very confused, congested choroid. Axial lengths were 25 millimeters and a little more. Uveitic profile otherwise was normal, and diagnosis was revised to left eye uveal effusion syndrome. We treated this patient with parenteral dexamethasone, and in no small part on the basis of what Shields had reported, success in 104 eyes of uveal effusion with steroids. Unfortunately, over the weeks, subsequent weeks, equity decreased. There was progression of uveal effusion syndrome, increase of subretinal fluids, disc edema. You can see that massively increased and turgid choroid. Exudative detachments came in, choroidal detachments came in, so much so that there was imminent angle closure and mandated YAG PI. You can see the inferior detachment there that drove us to advise subscleral sclerectomy. Unfortunately, the patient opted to wait and was lost to follow-up for 3 months. But when the patient came 3 months later, to our delight, there was spontaneous resolution of uveal effusion syndrome. You can see the complete resolution of the SRF and the RD, leopard spot retinopathy, and post-cataract surgery, equity improved to 612 and has been stable for the last 1 year, and we've written this up. So now tying the CSCR, pachychoroid, and uveal effusion syndrome together, work from Spade and the Japanese group led by Matsumoto tells us that in pachychoroid, the discrete segmental nature of the vortex vein system is lost. Anastomosis happens. These anastomotic vessels, some might call it pachyvessels, trespass the sacrosanct watershed. When these anastomoses are seen in the macula, you get CSC or pachychoroid neovasculopathy. When it's around the optic nerve head, you might get peripapillary pachychoroid syndrome. Now, this increased turgescence, hydrostatic pressure, and hypopermeability kicks up the uveal effusion syndrome pathology. And therefore, CSR might very well, in this setting, be a harbinger for uveal effusion syndrome. And vortex vein, as described by these papers, implicated in pachychoroid, we know that vortex vein decompression was one of the therapies suggested earlier for uveal effusion syndrome. And you see in our case, you can actually see those pachychoroid vessels, the anastomotic channels sweeping up into the macula, and therefore that CSR was an atypical one and perhaps a harbinger of this uveal effusion syndrome. So the unique features of this case was CSR morphing with uveal effusion syndrome, features of pachychoroid, and spontaneous resolution of the uveal effusion syndrome, prompting our pathogenic postulate that UES may lie at the extreme end of the pachychoroid spectrum, and that in a case of pachychoroid, when you see vortex vein anastomosis, short axial and choroidal folds, that should raise red flags and suggest that if there is this decompensation of pachychoroid, it may lead to incipient CSCR and then a full-blown uveal effusion syndrome. So CSR can also mimic other diseases, like it can mimic choroiditis. Very commonly, this happens, and the subretinal people can distort the leak, as seen here, and sometimes people can mistake it for CNVMs. The leads will show up. What looks like a case of IJT is actually a case of inferior of a CSR with the inferior gravitational tract, and seen on the angiogram too. Diseases can masquerade as CSR too, as this young female who had reduced vision over 3 days, equity 618 parts, multifocal serous detachment seen in the right eye. Angiogram shows these point leaks, CSR-like point leaks showing up. But what is the real giveaway here is that disproportionate amount of subretinal fluid, which you see on the later angiograms, on the fluorescein is pulling, and more importantly on the ICGS, a very large disproportionate area of hypocyanescence, which is totally disproportionate for those little leaks out there. OCT further firms it up with the septate fibrinous material and the tent-shaped PEDs, which is not typical of CSCR. And ultrasound fixes, confirms it with the subtenon fluid. It's a case of posterior scleritis. Uveitic workup was normal, and proof of the pudding lies in the pudding, where melt down with the steroids, or almost rapid loss, regain of vision, and the melting of the inflammatory material completely. Another masquerader is this particular kind of case where you have what looks like CSR with subretinal fibrin or a differential of an AMD. The angiogram shows no leaks. OCT in the right eye shows sciatic edema with a bit of atrophy. The CSR at different levels shows serous fluid, and this is why one could confuse it with CSCR. And you see that floccules are at level C below. But it is autofluorescence which shows this to be a case of adult onset foveal macular from dystrophy with the streaking lipofusion latent material. Another case which looks like an inferior gravitating teardrop tract of CSR is actually dome-shaped maculopathy. You see the diffuse leaks there. This went away with TTT. Another case which looks to the casual observer like a CSCR with a diffuse leak is actually focal choroidal excavation, and this went away with PDT. So in summary, central serous choroidal retinopathy is a common macular disorder, has protein presentations, and recognizing these varied manifestations and distinguishing them from other serous and exudative maculopathies is often the most challenging step in the management. Thank you. I think we lost Manisha a little. So may I invite comments from Dr. Anita first?
Couple of things. One was, the posterior pachychoroid disease. I had one patient in 2008 and 2009 that I had this guy after cataract surgery, and I took him to the OR thinking I'll decompress as posteriorly as possible and see if I can come a thinner sclera, because there was no leak, so I couldn't really do PDT. And there was one time there was a little leak near the disc. I did PDT, the fluid went away and came back within 3 to 4 months. Anyway, I went and looked at his sclera, and it was nothing like uveal effusion sclera. So it's not thick. It's not, I don't think the problem is in the sclera. I think it's in the choroid and the vortex vein and drainage. So I'm not sure scleral decompression with making scleral windows is a good option. Maybe there are selected cases that we can eventually find that have maybe localized thick sclera that we can measure before we go and take them to the OR, because I did this long ago, maybe 12, 13 years ago, and really didn't.
Yeah, so actually with uveal effusion syndrome, there are 3 categories. Yoyama said that. So the issue is not with the nanophthalmic short eye. There it works. There you have to create the alternate drainage channel. The issue is with type 3 uveal effusion syndrome, where you have normal axial length and normal sclera, which you have to do an MRI or histopathology to make that out. But our case was most probably a type 2 uveal effusion syndrome, where success has been partially reported with sclerectomy. But in the Shields, a large sequence of 104 eyes where they showed in type 3, where sclerectomy does not help. And that came on the basis of just 2 cases in that Yoyama series. That is where Shields group has reported success.
I know. I think adding the steroids probably worse than the CSR
component. That is my experience. My experience with this. So we took a shot because this patient was very high risk, was not willing for surgery at all. So we took a shot, but as you saw, it did worsen, and then fortunately, thank God, it improved.
Yeah. So the bottom line is most of these posterior pachychoroid or the chronic CSR ones don't really respond. Definitely get worse with steroids, and they don't really respond with scleral windows. So that I would keep outside of the thing. Absolutely. And I think the one that you had towards the end, the focal choroidal excavation CSR, I think they're both the same disease in that person, in the sense of focal choroidal excavation is probably a result of a CSR. I don't think they're 2 different entities. So I think you treated the CSR component and things fluid went away, and the focal choroidal excavation remained. When you're doing TTT, I'm interested in knowing what parameters you use. We've never really done TTT in any of these CSR eyes. I don't know if others I don't know if Jay has any experience about it, but it's interesting to know because looks like India doesn't have the laser or doesn't have Visudyne, right, for PDT?
Absolutely. Yeah, we don't. So this was a long time back. I mean, when PDT was very much around, just that these patients couldn't afford it, and that's why we used to do a huge amount of TTX, especially for extrafoveal pathologies, and we saw that in that ripped area. So we tried to get in. We tried to determine the threshold power, and then we were about 30% less than that, and that seems to help. So
and you used just regular
A10. Yeah, just dry laser. Yeah. Okay. So if I could bring in Jay on this, Jay is somebody who's our resident CSR expert. So Jay, I know you're itching to weigh in.
I really don't think that we have much time, but phenomenal cases as usual. But I think particularly the case with uveal effusion syndrome and CSR, as Anita correctly pointed out, that not all cases have thick sclera. But I think there is definitely some evidence which is coming across where they have shown from Japan that where they have shown anterior sclera has been found to be thick. But honestly, how much can we trust that how thickened the sclera is anteriorly and similarly it is thickened in the posterior pole as well. But the paper which talks about the venous overload choroidopathy, which just came in PRER, which clearly is trying to redefine all the diseases in and around choroid and leading to different presentation. So I think we all have to learn to look at the venous congestion primarily by using the wide field indocyanine green.
Yeah.
I think we should move on.
Yeah.